Awesome. Next, I'd like to introduce Allison Lipscomb. So Allison represents a different perspective on digital health, working for the NC Health and Human Services as a data specialist. And she's seeking to use technology to improve a long-standing Farmworker health survey that's been going on for many years. And which it needs to be culturally meaningful to the farm worker and give them an opportunity for health education as well, and as well as gathering data for the government. And I think this is interesting because I think a decade ago, maybe, then this would have been relatively unfathomable to think about doing it in this way. But I think it opens up these new potentials that have never before been possible. So with that, I'll pass it over to you. Thank you.
Thank you, everybody. I feel like I've heard TED Talks all morning, so there's a lot of potential here. There's a lot of exciting things going on. It's really inspiring. The wheels in my mind are turning. But I do bring a different perspective. I work out in the field with farm workers. I don't know a lot about technology. I'm learning a little bit. I'm learning a lot today. I do know a lot about farm worker health, and I know a lot about what our needs are. And so I'm really happy to be here and hearing from you all about how maybe any ideas you all have in the technology that we could use to do our jobs better. So I actually did my maternal and child health degree at UNC around 15 years ago. So it's really exciting to see the growth that's happened on campus and these new initiatives that were talked about earlier. And I also did outreach with farm workers for 8 years out in the mountains. But now I'm at the Office of Rural Health, which is in Raleigh. And I'll go through these slides a little bit quickly. We're the first state office to focus on rural health in the country. And we have various programs that I'll talk about. We don't provide direct patient care, but we administer a lot of programs that support and fund initiatives around the state to support patients that are in need. Here are the different programs. I apologize for the busyness of the slides. This is like our standard template that I didn't design. So they'll get a little bit simplified soon. But we place providers into rural settings. We have rural health centers that we support, community health grants that support a variety of initiatives that different organizations can apply for to support like EHR development, for instance. We have a new rural health information technology team, and I know Donica is here in the back representing. She started this week. That's helping health centers and rural health clinics get connected to the HIEA in North Carolina. And my program is the Farmworker Health Program, which I'll talk more about. This is the map of our coverage across the state. And now we're into our slides. So the Farmworker Health Program is a smaller program at the Office of Rural Health. We are actually a HRSA-funded migrant health center, so we get federal funding. And we don't provide services directly like I mentioned before. We contract with 10 contract sites around the state, so you'll see the locations around the state there. There are also 11 migrant health centers that are freestanding in the state, but what we do is kind of fill the gaps where those migrant health centers are not sufficiently meeting the needs. So there are a lot of migrant health centers in the eastern part of the state where there are a lot of farm workers, but you'll see kind of out in the west and in the middle of the state, we have like these smaller programs that provide outreach to farm workers and then piece together care. So our partners include hospitals, health departments, rural health clinics, community health centers, community-based nonprofits, and we provide grants to them to go out and find farm workers. So a big part of our job is outreach. So I was, like I said before, I was an outreach worker in Boone, North Carolina for a long time. Outreach workers go out and visit the farm workers in their houses at night. And I should probably talk a little bit about farm workers, but I'll do that in the next slide. But there are about 150,000 farm workers and their family members in North Carolina, and they face various barriers to care. But our work at the central office, there's a team of 7 of us, and we administer the funds that we give to the contract sites. We track the productivity and quality of services. We comply with federal requirements, and we provide training and technical assistance to outreach staff. And our work is very data dependent, as you can imagine. We have to report back to the federal government on the kind of services that have been provided. So to kind of paint a picture of what farm worker lives can be like and how outreach serves them, I want to read a poem by Dr. Gail Thomas. She's our medical director, and she's also on faculty here at UNC School of Medicine. And her poem was selected as the first place winner of the 2017 Society of Teachers of Family Medicine Poetry and Prose competition. and it's been recently published in the Journal of Family Medicine. And she works on a mobile unit that goes out to farmworker camps on a weekly basis during the summer east of Raleigh near Benson to provide medical care on a van. So here's her poem, The Migrant Farm Worker. We arrive at the twilight to the camp hidden in the fields. Bats swoop low, stars come out. The distant summer thunderstorm flickers and rumbles. He and his fellow farm workers gather. The monotony of dawn to dusk labor broken by our presence. As tables, lanterns, charts, and blood pressure cuffs are set out, he offers us water, hospitality, his handshake. We work to deserve his trust. Bearing witness to his industry and expertise, we inquire after his family, admire photos of those for whom he toils, and race to finish so he can rest before his daily pre-dawn rising. His hands harvesting sweet spring strawberries rash and itch. Is it pesticide or plant? His back bent for hours priding tobacco aches at night. Is it oppressive ergonomics or systems? His eyes, exposed for years to sun and dust, cloud with pterygia. Do they dim his vision of his future? His shoulders bearing heavy bins of sweet potatoes wear at the rotator cuff. Are 45 cents per bin worth what he pays in pain? His arms plunging into ripe berry bushes are scratched and scarred, but how to tend the scars of separation on his soul? His body, brushed by dewy tobacco leaves, involuntarily absorbs nicotine. Why should he bear the burden of our cravings? His mind, once aspiring to creativity, is now depressed by isolation. What could he have created? His heart, justly proud of hard work and provision, is broken by injustice. Does our care, though compassionate, serve as scaffold for the sin? We are the consumers. Is he the consumed? I think it's really nice to have a poem. I think it can tell a lot more than anything I could really describe. But I will kind of add a little bit to that. So, like it's mentioned in the poem, farm workers have a lot of specific health risks. So they have occupational health risks, such as tobacco sickness, which is like an acute nicotine poisoning from exposure to the tobacco leaves, skin rashes, eye irritation, backaches, sun exposure, heat illness. And in addition to that, they experience the mental health and substance abuse concerns of the isolation that they face, being far away from their families, far away from their homes. Also pesticide exposure, of course. And Dr. Thomas didn't mention these in her poem, but we also see a lot of farm workers with severe dental needs, also chronic disease such as hypertension and diabetes. So just to give you also some more context on farm workers in North Carolina, our program served around 10,000 farm workers last year, and they work in crops such as tobacco, Christmas trees in the mountains, sweet potatoes, cucumbers, strawberries, tomatoes, and I'm imagining, has anybody ever seen a farm worker camp here? Not really. They're largely invisible populations. So when I first started doing outreach, it was in Wake County, and so you'd be like next to a suburb in a neighborhood, and next door to that would be a trailer with farm workers, and you might never have known that. So a lot of what our outreach programs do is help break that isolation down and connect them to the outreach workers, and then the outreach workers provide care to them. Farm workers are seasonal and migrant, so you have seasonal workers that stay here year-round and live here year-round, but work seasonally in agriculture, and then we have migrant workers who come from Mexico on an annual basis, sometimes with a work visa. Sometimes they migrate up and down the eastern stream from Florida up to New York. A lot of the farm workers we serve are men from Mexico. They may have their families here with us, but a lot of them have family members back home. And despite the increased health risk I talked about earlier, there are a lot of barriers to health care. So not many of them have health insurance. Some of them have gotten health insurance through the Affordable Care Act now. If they have a work visa, they have to get health insurance through that or pay the penalty, which has been interesting. But a lot of them have very low incomes. They can't take off work to go to the doctor, so they depend on evening hours to get care. Of course, there's language barriers, transportation. A lot of them don't have cars. And so that's where we have these outreach. I'm going to go back, actually. So this is what Farmworker Health Outreach looks like. This is one of our sites that's in Benson, east of Raleigh, like I said. And the van you see here is a mobile medical unit. So not all of our sites have mobile medical units, but some do. They bring the clinics out to the fields, and they work until around 10 o'clock at night. So they go out at 5 o'clock, go visit the farm workers in their housing, and come back at 10. Our model really focuses on enabling services, which includes outreach, case management, and health education provided by community health workers, what we call as outreach workers. One big key that I'm going to talk about today is we use something called a health assessment. So the outreach workers will approach each farm worker each season and do a 2-page interview with them about their health needs, and we'll talk more about that. Based on that health assessment, they'll do health education to address topics that come up during the discussion, and they'll also do all the follow-up care afterwards to get them into primary care, dental, behavioral health, specialty, whatever is identified as a need during that health assessment. They also provide the transportation and interpret and do the case management. So it's a very busy job, and one of the real joys, like I say, from doing it myself is getting out there, but also getting to know the farm workers. We have the same farm workers come back year after year, and eventually with my program we got to go to Mexico and meet their families, but there's a lot of relationship building that goes on because you need that trust to access them and their housing. So this is kind of our problem right now. We have a health assessment we've used for many years, as Brian said, and it's 2 pages. The print's gotten tinier and tinier. And because we keep trying to do more and more with it, because we might only see the farm workers once the whole year, and so we try to cover everything we can in that setting. On the flip side of that, if you know anything about motivational interviewing or patient engagement, trying to cover too many things at once could really leave nothing really covered. So we're starting to question that process a little bit. But you can see here, and you can't really see it too well, but the top part is all demographic information. So at the end of the year, we have to report back to HRSA, our funder, through the Universal Data System, UDS report, on who we served. So basically, their demographic information and what services were provided. And the demographic information as well keeps getting bigger and bigger. So it's veteran status, homeless status. They've added sexual orientation and gender identity. So all these questions are asked of every farm worker out in the field. We also check their vitals. So we check blood pressure and BMI. And then there's a series of questions to engage them. So the questions are, do you have any health concerns? Starts out that way. Starts to get more specific. We do a CAGE screening. We do for substance abuse. We do behavioral health screening. We do pesticide exposure screening. And it takes a long time. So we talk about seatbelt use, tobacco use. So again, it's gotten to the point where it takes maybe 20 minutes per patient. At some of these sites, we're trying to reach thousands of patients, and they only have a limited window to engage the patient, which is in the evenings. All the questions as they are asked could prompt health education or follow-up. So that's really some of the point, is to engage in conversation, not just to collect data. And then, on top of collecting all the data, the next day, that's the goal, sometimes it's many months later, the outreach workers come back to the office and enter that data into our data system. So, we're ready for a change. In 2017, we did some surveys, interviews, and focus groups with our central office staff, outreach workers, and farm workers to find out how they felt about doing this health assessment. Not surprisingly, this is the voices from our office and the outreach workers, but the data entry is quite a burden for them. It means less time spent with the patient. The length of the form has gotten burdensome for the farm workers. I know sometimes when we would arrive to camps and we had seen the same farm workers year after year, it was embarrassing because they could repeat the questions back to me. Or sometimes they would avoid us because they were tired of doing the survey. And then I think over time too, now we go to camps, farm workers are on their smartphones. And so I think before, farm workers were really engaged, they were excited we were coming, and it's not that they're not anymore, but now there's competition with the smartphone and the screen. So trying to get them to disengage from the screen to do this paper assessment is more difficult. We'd like to make the questions more open-ended and more patient-directed and not so close. Do you smoke, yes or no? Some questions are very personal. We talk about HIV testing, we talk about behavioral health and substance abuse, and now we talk about sexual orientation and gender identity, all within their housing, so there could be other farm workers around. So, and farm worker voices, key to all this. We did some focus groups this summer in fall with farm workers to find out what they thought. And research shows that farm workers are using smartphones. This was research by Wake Forest in 2012 and 2013, saying that most vulnerable Latino farm workers living in North Carolina own cell phones and a substantial minority own smartphones. That was 5 years ago. It's increased significantly since then. There are a lot of free, not free, very low-cost cell phone services coming out of Mexico. So they get their phones before they come, and they're using them, of course. They're using them to engage with their family, engage with music. It cuts down isolation. So we also did some focus groups this summer. They found, Farmworkers reported they're using their smartphones for WhatsApp, Facebook, video calls, text, to distract themselves. Like I mentioned, mental health is an issue, so they're listening to music. It was really important to them. And they're interested in health education videos on their phones. We also talked to them about the health assessment. They said they wouldn't want the relationship with the outreach worker to be replaced by a screen. They really value that human touch. But they are interested in having their own personal health record. Right now we're collecting information and they don't really get it. So they'd love to have a copy of it themselves or have it on their phone. So how can technology help? So we are contracting with, I actually met through Brian, I met Michael Levy with Blue Door, which is a local health innovation design company, to figure out how we can redesign our health assessment, and we are engaging the outreach workers in that process to do so. So next Friday we're going to have a design session with them to figure out how we could redesign this. Some ideas as well that Michael's group has is, could some of our processes be more automated in the meantime? So could some of that data entry they're doing be done through robotic process automation to get some of that information off the forms into our data system? We're also hoping to develop a mobile app that the outreach workers can take into the field that would collect this information. Also, we've thought about, through Michael, chatbots for health education. So, rather than repeating the same message to farm workers, it's hot outside, drink water, when the time comes and we're having a heat advisory, could we send automated messages out through smartphones and through cell phones to remind farm workers, now is the time to really be careful, take breaks, drink water, and that sort of thing. And I'd love to hear your all's ideas during the Q&A as well. But it's interesting, though, that technology is finally entering this line of work because it has been such a low resource field for so long. We work on paper, we pride ourselves in doing a lot with small resources, but now that technology is more accessible, I think that we can integrate it more. There are some apps already out there, so Contratados is an app where it's almost like Yelp, so farm workers can rate growers, which is kind of nice. And they can share their experiences if they had a bad grower, and that can help people if they have the choice to choose a better grower. Conectate Carolina is an online directory of services in North Carolina for farm workers. Legal Aid North Carolina has a Facebook page which is really active with education. OSHA has a heat advisory app, so we've also, it has it in Spanish as well, so we educate farm workers on that. And then, we have just a second, we actually produced a health education video on health insurance. And I get to be the evil nurse in the video, which was really fun. But it's based on a telenovela style, like a soap opera style, which is really popular with this population. You might not be able to get this going, but that's okay. But in the meantime, I'll talk about, we're also doing more with behavioral health, and we're looking at using telehealth so that So this has been really fun. That's not me. I come later. But that is one of our outreach workers, actually. But that was a really fun video to make last year, and they played it on the buses as workers were coming from Mexico. We're giving the links out to them and encourages them to enroll in health insurance. So there's a lot of potential out there. Like I said, we're looking at using telehealth for behavioral health therapy with farm workers. A lot of farm workers need behavioral health. They're in isolated rural locations without bilingual providers, and our hope is that we can do telehealth, and so that we can reach farm workers even in their own houses to reduce some of the stigma, and connect them with bilingual behavioral health providers in remote locations. There's also a lot of other health monitoring apps such as diet, hypertension, diabetes in Spanish. Univision has a lot of apps as well. And so we're looking at trying to figure out what might be most popular with farm workers and leveraging that and getting that information out to them. Some other possibilities are biomonitors, such as heat in the fields. But that's it. It's kind of growing. a lot of opportunities out there, and we're just at the beginning of it. So I appreciate any feedback you all have on where we might go with this. But let me take this back.
And any questions?
So you said you're working on automating the form, or and is the goal to ultimately provide that personal health record for these farm workers?
Yes.
Would that be, would those two go hand in hand, or do you kind of bring your form in for your needs, and then it might not be so easy to turn around and provide that as a
Right.
personal health record?
So when I did outreach, we collected this information. We made little little paper things where we could write down their blood pressure and give it to them, because I felt like we were taking from them but not giving back. I mean, in the bigger picture, of course, the idea is that we are providing services, but we were taking that information and not sharing it with them. But I think ideally, I don't know we'll have the capacity to afford, but hopefully we could do something that patients can access as well, or at the very least provide like a picture or something of their record that they can take on their phones. And that's really helpful for them, because as they migrate, they can take that health information with them.
Right.
Yeah.
I asked them, and we could talk later, but
Sure.
there's quite a bit of commercially available PHR, personal health record
Okay.
solutions out there, and it's been, if folks have followed, it's been a market that's been around for a while, but has not really taken off. And every year, like, oh, this might be the year, this might be the year.
Yeah.
And if you follow Apple, they recently have their health records where they're going to allow you to pull the data from all your multiple patient portals into your own, on your phone only. And so it's headed that way, it seems like.
Yeah.
I mean, Apple's putting a lot behind it as well as others. So, but I realize you're going to have a lot fewer resources than, say, Apple and others.
Yes, if anybody knows the resources, that's
But
awesome.
you mentioned that the farm workers are not just in North Carolina, like they may spend time here and others. So it just seems like, to the extent you can provide it, and I'm sure you're thinking of this, for them
Yeah.
to have their own health data, it's just going to, just like we talk about with all others, empowering the patient and informing them, and then they can be their own best advocate.
Definitely. And just to add to that really quickly is that getting results back about immunizations and pap smears. So we ask women, have you had a pap smear? And they'll say, yeah, but they don't have any record of it. So then there's a lot of going back and trying to get that record or having to repeat it. But there could be ways to get that more centralized and be a little bit more efficient. Yeah. Yeah.
Looking at your farm worker program, it looked like you're covering it about half of the state only. What's the funding mechanism, and is there a prospect for improving that coverage, because the eastern half and the western half are kind of not there?
Right. So that was just our 10 contract sites. There are 11 migrant health centers that are funded directly by the government. And those tend to be, especially out in the east, where there's a really high density of farm workers. And so those are independent community migrant health centers, whereas we're focusing on kind of the gaps already. Going backwards, trying to find that map. But there are some counties that we'd like to expand into, and that's why if we can get to a point where we're using our money more efficiently, then we can look at expanding.
Where does your money come from? I missed that.
HRSA, so the Health Research
Okay.
Services Administration. So this is, like all that eastern part is mostly covered by a network of migrant health centers. Hendersonville has a lot of migrant farm workers, so they have a migrant health center out there. The Watauga area, that's where I was, and then turned into a migrant health center, so they're no longer funded by us. So a lot of these other areas are being covered by other programs.
Thank you.
Mm-hmm.
Are they operated independently, though, you're saying?
Yeah.
So they're like a
Yeah.
for-profit or not-for-profit organization?
No, they're not for profit. So they're community and migrant health centers that are federally funded as well.
Okay.
So like we're funded as a migrant health center, and then rather than provide the services directly, we contract out to these different. It's a non-traditional model. Yeah.
Was there, and I may have missed this, was there an economic impact to North Carolina from migrant workers going for ER care? What's the impact we have?
We don't know, and I think part of that is data not being collected.
Right.
So when I was in Boone, we tried to get that data from the hospital, and I don't think they were even collecting in terms of Spanish speakers versus non-Spanish speakers, which I was really surprised at. But I don't think providers are consistently asking about occupational status. So trying to get that farm workers, because I know some of our sites have been interested in that because they want to say, hey, hospital, you can invest more in our services and we'll help divert some of these ER visits. They're just not able to get that data yet. But it's a great idea. Are there questions, ideas? Yeah.
I'm just curious, how supportive are the farmers of working at
Yeah, it really varies. We have some that are much more engaged and inviting. Some are a little more hands-off, and then some that are a little bit more belligerent, that aren't, wanting people on their land, or that they confuse our health outreach workers with legal aid or a union, because there is the Farmworker Union in North Carolina. So that's one of the issues, is access to camps. And so documenting when there's issues of access, like some of our outreach workers have been confronted with a farmer with a shotgun, and so trying to report that and get that information out there, and to communicate to the growers that this is really a program that can help you and fill in the gaps of maybe care that they're not always providing either in terms of insurance, health insurance. So,
Thank you.
all right, thank you.
That was excellent. I'm so happy with so many of these talks. This is wonderful. So for the next about 45 minutes, we have a triple threat, which is lunch, posters, and demos. The poster sessions are across the hall over there, and people can probably direct you if you don't know where they are, but we've got a bunch of posters for you. We've got some demos, so as I've mentioned before, they're down this hallway and around here. There's also one up on the 5th floor, so that one is the VR experience, the virtual reality experience for anatomy, with Jason Sherrill, who's going to be speaking to us later on today. But the other ones are ChiCore is here down the hall, CrossCom, which is, so ChiCore does digital health interventions and research. They're a UNC group, and so if you're trying to put something together, they're wonderful people to talk to. CrossCom has an AR headset demo, which I'm personally excited about, the Meta 2, which I've never played with before. Gotten to use in a technical manner. The Elite HRV, which we've talked about, is here. Fleet Feet, to scanning your feet, which we've talked about before. Next Gen Interactions is the one upstairs where you can do the VR demo. Keenan Science Library is here with 3D printing and a VR demo, so you can check them out next to the poster session over there. And of course, the Health Sciences Library. You can check out our digital health collection. So if you can check it over there, we have a brochure about it. You can come talk to me about it or to Lynn, and that's down the hall here.